Hello, and it's an absolute pleasure to be with you at the symposium, and thanks to Mohammed and the entire team for inviting me. It's very, very kind. I wish I was there, but we'll still do it remotely. We're very used to this now. We're going to look at a deep dive into ankylosing spondylitis. Is there a place for JAK inhibitors? Here's the disclaimer, and here are my disclosures. So the objectives of the meeting are to recognise the need to achieve stringent disease control earlier to improve outcomes in ankylosing spondylitis. I also want to illustrate how current treatment options are doing in reaching those targets and discuss how JAK inhibitors fit into the current treatment algorithm of AS. We know that there's a heavy disease burden with ankylosing spondylitis, ongoing pain and stiffness, and affects quality of life. And we can see that the condition really does limit people who suffer from AS, and particularly the pain issue, which really permeates their entire world. And 83% of people with AS report problems with pain often to a very large extent. Levels of pain remain high despite biologic therapy. Here we see that patients, even who are on biologic therapy, report high levels of pain. 38% still have high levels, and many more have ongoing pain despite anti-TNF, which is what we would consider our best option until recently for managing AS. We have an international task force on looking at disease remission or low disease activity. This is borrowed from rheumatoid arthritis, of course, and what we're trying to do is optimize the care, reduce their disease burden as low as possible to have them free of symptoms so they can lead normal lives. And this should be our goal in every patient. We have drugs that we have used for many years. Anti-inflammatories have a number of side effects. We have anti-TNF agents, anti-IL-17 agents that are available. But some of the other biologics have not been successful. Anti-IL-12/23, anti-IL-23, and PDE inhibitors also have not been effective in AS. But what about JAK inhibitors? So we're going to come on to that soon. We have treatment guidelines from the big august bodies that issue guidelines, the EULAR recommendations, the ACR recommendations. Now, of course, the EULAR recommendations are now 2016, before JAK inhibitors were studied extensively in AS, and the ACR recommendations was in 2019. There was a little bit of controversy here because the third-line therapy of JAK, which was tofacitinib, for primary failure, was based on phase 2 data. Now, people knew that there may be a benefit of JAK inhibitors, and therefore that was included in these recommendations. We have anti-TNF. I guess that's our main drug, or has been our main drug, but that's not for everybody. Certainly etanercept is not a good idea in patients with bowel disease and eye disease. And anti-IL-17s, one needs to be particularly careful in patients with inflammatory bowel disease. In fact, I have a patient, just my colleague called me today, of a patient who had a flare of inflammatory bowel disease on anti-IL-17. And also, methotrexate is usually required with anti-TNF to optimize care, and people don't really like methotrexate overall. It has a number of limitations as well, and certainly not effective for axial disease. What about anti-inflammatories? Well, we know there's a significant risk of side effects on non-steroidal anti-inflammatories. There's the gut issues, there's kidney function, there's blood pressure, and a number of other long-term side effects. So really, my feeling is that if a patient does require long-term anti-inflammatories, even if they are responding, that we should look for other agents in order to optimize their care. But at the moment, many people with back disease, inflammatory back disease, do take long-term anti-inflammatories. And we need to be, again, very careful of that because of the side effect profile. How have we done so far with ankylosing spondylitis? Well, these are pretty poor results when you think that biologics were really meant to help dramatically. Here we have the majority of patients with AS failed to achieve disease activity targets despite biologics, adalimumab, etanercept, golimumab, infliximab, certolizumab, secukinumab, all really less than or around 20% achieving an ASAS partial remission. So these are fairly bad results when we're looking to really get people into disease remission, as many people as we can. It's only about 1/5. Even worse in some respects in the real world. We have a number of biologic registries that are looking at this, including the BSRBR and then DanBio. And remember here, the BASDI response is just a response, not a low disease remission response. So that looks quite high there, but you can have a disease response on your BASDI, but still have ongoing active disease. So really, we have still a long way to go in order to optimize the care of the patients. So there are, just to highlight again, there are limitations of biologic therapies. There are potential drug discontinuations due to intolerance or adverse events. And of course, not everybody responds or fails to respond over time, or the effect stops. And I see that quite commonly. There is immunogenicity, particularly with anti-TNF agents, and that can trigger anti-drug antibodies and then reduce the efficacy. And of course, there are injections, and many people do not like injections. And when you offer them an oral option, they're very keen for this opportunity. And they get used to the injections, they take them, but if there's alternatives, then many people are very keen for that. So here we have the JAK era. We had the anti-inflammatories for ankylosing spondylitis. DMARDs didn't work at all well. We then went on to biologics, and we've seen the limitations of biologics. Now we're on to JAK inhibitors. So two have been specifically studies in this area that have been approved, in fact, only the upadacitinib approved now by the Saudi FDA. But the other study was tofacitinib, the 5 milligram BD dose. Now you see the primary endpoint and ASAS 20 response at week 16. And then UPA in select access, the 15 milligram dose in biologic DMARD naive patients with a higher primary endpoint and ASAS 40 response at week 14, as well as the hard endpoints, radiographic MRI changes. So really, very stringent outcome measures in the select access 1 study. And what did we see? Just coming back to tofacitinib, so it achieved disease control here with the ASAS 20 and the ASAS 40 at week 16. We see around 40% of people achieving that primary endpoint. So just to highlight that upadacitinib is the first JAK inhibitor to receive EMA and Saudi approval for the management of ankylosing spondylitis, also licensed now in Australia, the only JAK for ankylosing spondylitis in Australia. I'm very happy that that's allowable and starting to use it commonly in the clinic. So as people know, it's an oral therapy, small molecule, and therefore really no immunogenicity. We're using the 15 milligram dose, and it is essentially for people who have failed to inadequately respond to anti-inflammatories. And that's how we get funding also in Australia, patients who've failed on anti-inflammatories. But of course, upadacitinib is also approved for rheumatoid arthritis and psoriatic arthritis. Here we look at the stringent disease activity outcomes, the ASAS 40 at week 14 and week 64, ASAS partial remission, ASDAS low disease activity, ASDAS inactive disease. We're seeing benefits already at week 14, highly statistically significant to placebo, and then these continue out to week 64. So there's response, and this response continues out to week 64 in all of these stringent outcome measures. And here's another way looking at sustained disease control. out to week 64. You see the grey line with the placebo arm that then switches on to the UPA and then catches up to those who received UPA the whole time with really, very good responses, ASDAS partial remission of 40% at week 64 and similar outcomes with the ASDAS inactive disease at that time point as well. What about the aspects of pain? We touched on that earlier. This is the main problem for the patient, no matter whichever way you look at it. Patient global assessment, back pain, nocturnal back pain, very troubling, spinal pain, peripheral pain, all greater benefits above placebo with upadacitinib at week 14 that extends out to week 64 in these varied manifestations of pain. And also looking at the hard endpoints I mentioned, the MRI changes, both at the sacroiliac joints and the spine, we see reduction in inflammation, and also the laboratory is expect a rapid drop of CRP with UPA starting early, already at week 2, and this continues out, and then also the placebo arm then switching over and seeing a rapid drop in the highly sensitive CRP. And here we also have the sustained improvement in function. That's what I look for with patients, their functional limitation. We have to improve their function. That's what's meaningful to them. And here we see the benefits at the BASDI level, the BASFI level, functional index at week 14 that continues also out to week 64. I'm going to come on to the safety data in the next presentation, but it's suffice to say that it is extremely well tolerated in this population, maybe reflecting the demographic of the individuals. So in summary, we've had limited pharmacological treatment options for axial spondyloarthritis, ankylosing spondylitis, and despite biologic DMARD use, people still have active disease and are not achieving those targets. And now we have a further option, upadacitinib, the first JAK inhibitor to receive EMA and Saudi FDA approval in Australia as well, and achieves the multiple stringent disease activity targets and is well tolerated. Thank you very much for your attention.